I'm also letting people in the room. Good morning, everybody. My name is Sharon Prince. I'm a consultant clinical and forensic psychologist and the chair of the North East Yorkshire Psychological Professionals Network. Welcome to the last day of PP Week. And I'm really excited to hear this morning's session chaired by Dr. Liz Jenkinson and colleagues. Housekeeping, there are no fire alarms. Please be mindful that this session is open to psychological professionals, members of the public, other stakeholders. So you could hold that in mind, please, with comments and questions. I understand that there will be, please put any questions in the chat if you'd like answered, and there will be opportunities at the end of the session for questions. I'll stop talking and let you crack on.
Oh, thanks very Sharon. Much. Liz, shall I just say a big thanks to all of our speakers today, including to yourself. I don't know, Liz, are you going to be able to share the presentation first? Since you're the first speaker, and then we will have 3 case studies from health psychologists working within the UK who are already working on areas regarding moving from hospital to community. If anyone could put any questions in the chat, I will collate all of those questions and we'll have kind of a panel Q&A in the last kind of 20 minutes or so of the session. Liz, shall I hand over to yourself?
Yeah, I'm just finding the PowerPoint. I wasn't sure which of us was going to share it, so just give me 1 sec. I will just, as is with these things, there were some final touches last night, so just making sure we've got the right one to share with you this morning. There we go. I think that's the right one. Lovely. So, where is it on here? So thanks very much for that. See that on there. Is it that one? Would you mind sharing it, Kate? Mine's not playing ball very well here, I'm afraid. It's not picking up my screen. I'm not sure why. Maybe because I'm not on an NHS computer, perhaps. It's just saying it can't share content. Brilliant. Thank you, Kate. That's much appreciated. I haven't changed it this morning or anything. So I'm Dr. Liz Jenkinson. I'm a health psychologist, and I'm really pleased to be here to speak to you today about, the role of health psychologists in hospital to community. Could you give us the next slide, please, Kate? Thank you. Can I change it at the bottom? I can change it. Maybe. Oh, I can move it forward as well, so I don't need to. No, you have to do it by the looks of it because you're the presenter. There we are. Friday, tech issues.
I know. I'm just wondering, can I give you control of this, Liz?
Don't worry, I'll just do a Chris Whitty and ask you to move it forward after every slide. That's fine by me.
Okie dokie. Is that moving?
Yeah, there's moved. Yeah. Thank you very much.
Perfect.
Yeah, it has. So my name's first, but that doesn't mean anything. Kate's done just as much work on this as I have, as have all the other presenters that we're going to invite today. And we're all health psychologists. We work in the NHS, and we're really pleased to have this opportunity to talk about health psychology in the NHS and what we do, because I don't know how many of you are health psychologists in the audience. It might be great to know. Perhaps if you are, you can put an emoji in the chat to show us who is a health psychologist here with us today. And perhaps many of you are from other psychological professions. You might be patients, you might be aspiring psychological professionals, who knows. So it'd be great to know if we have any other health psychologists here. If you pop an emoji in the chat for us, we'd love to know. Oh, hello, trainee health psychologist as well. Well, it's great to see some of you here. We are quite a small group of professionals, actually, in comparison to some of the much bigger psychological professional groups. So we sometimes don't kind of have a chance to showcase what we do. So it's really wonderful that Sharon's asked us to do that this morning. Really exciting. And whilst we are relatively small in number, particularly compared to our clinical psychologist and counselling psychologist colleagues, we have got a really clear role to play in the NHS, particularly in the 3 shifts. So you'll have heard about those all week, I'm sure. But anyone who's new, I am just going to kind of take you through some of that and really highlight where health psychology can make a big difference in these 3 shifts that the Darcy review has suggested and in our new 10-year plan. So with us this morning are people who are using health psychology and are health psychologists in the NHS. I'd also like to acknowledge Adrian Whittington, so our psychological professions lead nationally, because I have got a couple of his slides at the start with his permission. Didn't just pinch them. So if you came to the start of the week, you might have seen some of this already. But I thought it's really important just to kind of underscore kind of where we're coming from here in case you're new to Psychological Professions Week. We've also had some input as well by experts, by experienced colleagues, and we really appreciate that as well. So it's been very much a group effort. I've just been nominated to kick it all off, but very much a group effort from the team. Next slide, please. Well, my slides aren't moving on. Don't know if anybody else's are. I've moved mine on. Can other people see that?
It did move, and then it's moved back again.
Oh, okay. Does it say this session on the top of it?
It does, yeah.
Oh, perfect. Thank you, Matt. Appreciate that. So I think I can move them forward now. Honestly, we should have checked this out first, shouldn't we? So today, in the time that we've got quite a while this morning. I'm going to very briefly overview the key things I think we need to know about the 10-year plan for this session, and the part that's from hospital community, which is our focus today, moving care from hospitals more into community settings. I'm going to try to highlight the role of health psychologists and what we could bring to that. And then we're going to move to our other speakers. So we're going to hear from the health psychologist on that first slide, talking through different case studies in their particular settings, and how they're applying that and the success that they've had. And then we're going to move to a discussion and have some questions from the audience. If you do have any questions as we go through, please do pop them in the chat. We won't necessarily be able to pick them up all as we go along. We are going to try to save them for that discussion at the end. But if it's something small that we might be able to pick up for clarification while we're going through, then we might be able to pick it off. So there's enough of us here to keep checking the chat box. So please do pop anything in there, any comments or questions for us. I'm hoping we're now on a fit for the future slide. People seeing that one?
Yes, we are, yeah.
Oh, yay. We're all synced now. Thank you, everybody, for bearing with. I doubt this is new to anybody on the call. It's been very much the theme of this week. But if it is, just to highlight, there is a 10-year health plan for England that has recently been released. And we're all trying to think, how will this fit with where we're going in terms of the psychological professions? You can have a look at this document. It's publicly available. So if you haven't seen it yet, you can go onto the government website and read what is being suggested about where we should be going as an NHS. Now, in that document and in that new kind of call to arms, I guess, is 3 shifts of our care, our workforce, our behaviour, the way we operate the NHS. Now, those 3 are moving our kind of approach from analog to digital. And what they mean by that in the document is upgrading and commissioning kind of new technology to make sure that what we're using in terms of digital solutions for NHS problems is fit for purpose. So we know, don't we, from working in our various areas, that sometimes we're not using the best technology that's fit for purpose. We certainly know that there isn't, for example, one patient record that we might be working with. It's often siloed and kind of complicated, and the way we store and manage our data could be streamlined. It potentially could be better. We also are starting to see some sort of really innovative work like robotics and AI beginning to be used in our NHS in an effective way. And so there's lots of opportunity there for psychologists and psychological professionals of all kinds to be involved in that change. I'm then going to move to the one at the bottom, which is sickness to prevention, which is about kind of hopefully intervening before we see healthcare issues becoming more serious. So we're looking at a more public health focused model. Early identification and screening will be important there in moving that forward, trying to encourage people to come along to things that they are offered so that we can identify and diagnose much earlier, and therefore we might be able to put plans in place to kind of prevent the more serious outcomes happening for patients. It also includes kind of management of existing chronic conditions. So there's a definite overlap there with hospital to community that we're going to talk about at the moment. So some real opportunities there as well for us in psychology, where particularly as health psychologists, which I'll talk about in a minute. Now, hospital to community is the one we've been asked to talk about today, and about how we might fit in as health psychologists and what we might already be doing to try to shift care from hospital settings more into the communities and the neighbourhoods in which people live. Now, the way this is talked about in the 10-year plan is in terms of bringing care closer to where people live. So there is a geographical element to it, trying to make it easy for people and give them the opportunity to access local services in a way that is going to be less disruptive to their life. It's going to be easier for them to come along to appointments when they're offered, and also perhaps they might develop a relationship then with ongoing professionals they might see locally. It's also couched as something that should be more proactive and personalised than maybe what people are receiving at the moment. Instead of perhaps going to multiple sites or multiple settings, they might expect to have more of their care in a neighbourhood hub or in one particular place that they might go to more regularly than going to many different hospitals. Within that, of course, there is also this idea that we need to get people out of hospital as soon as they can to move back into their homes and back into the community. So we're going to focus on that hospital to community today. But I'd also like to say that I feel strongly, and I think that was put across at the start of the week, if you went to some of the keynote talks about this, that psychologists and psychology and psychological professionals have an awful lot to bring to each of these three shifts. All of them need psychologically informed approaches, behaviour change, and they all involve people. You know, they all involve staff, they all involve patients. And actually, we've got a lot to bring as a community to helping these shifts be successful and effective. So let's focus now a little bit on the hospital to community one. The bits that have been picked out here in Psychological Profession Week, of course, are the ones that are most relevant to us as psychologists. This idea that we are going to potentially see neighbourhood hubs, health centres being rolled out. And there are some of these things starting to be piloted already. These health centres we can expect as patients and healthcare professionals to see these as open longer. So not your 9 to 5, they should be open earlier in the morning into the evening, with a range of services working together, but crucially based in communities. So geographically based in the community in which they serve. So that's one of the big ideas here within this, is making our sort of health centres more kind of multidisciplinary and more frequently embedded within the communities they serve. There's also some really interesting stuff there around mental health and neighbourhood mental health models. And again, this is already being trialled in certain settings to see how it works. And the big idea there is 24/7 mental health hubs. You know, we know that at the moment, often, you know, it's hard to access crisis care. People go to A&E with mental health concerns because they can't see their GP, they can't see, you know, somebody who they would normally see within the kind of 9 to 5 usual hours. Trying to address that issue, that actually mental health, it doesn't stick to normal hours, and crisis doesn't stick to normal hours, and that we need to think about more wraparound mental health care. And of course, that has a really big role there for psychologists and psychological professionals, mental health nurses, and the whole range of people working in mental health with psychologically informed work. There's also an aspiration to have more assertive outreach care. That's a longer range view, and the detail is less worked out at the moment, is my understanding. But we're starting to think more proactively about outreach in mental health, wellbeing and physical health. And there's a commitment within that hospital community plan of 85 new mental health emergency departments. So that more kind of crisis model as well, kind of being rolled out as well with quite a big budget assigned to that. So there really is a lot of talk about improving our mental health care services in in this, in the 10-year plan. But the bit for us as health psychologists, I think in particular, is these neighbourhood health centres and this move towards more community-based physical health care that is psychologically informed. And as I've been talking, I've seen lots of lovely health psychologists posting in the chat, which is great to see, and trainees. So, you know, thanks to you all for joining us. And when I'm saying health psychologists need to do this, obviously, I mean all of us. So it's great to see you all here. So this very much is one of Adrian's slides. I can't take credit for it. But, you know, there are lots of opportunities. Sorry, could everybody turn off their microphones? There's a bit of noise coming from some people's backgrounds. Thank you. There are 3 opportunities for psychological healthcare in the shift from hospital to community, in the way that, you know, we're sort of conceptualizing it within the psychological professions at the moment. So just zoning in on that hospital to community, there are 3 things that perhaps Adrian and the team really feel that we could make a really strong impact upon. One is to embed more psychological approaches to long-term condition management and rehab. Another is to enable this shift in mental health crisis support that we've just mentioned, you know, kind of having these more emergency care type models, but specifically for mental health, having more of a 24/7 approach, and how might we do that effectively? And then addressing the psychological treatment gap more generally. People should have access to psychological support alongside other treatments as well. Now, I think today we're specifically really focusing most on embedding psychological approaches to long-term condition management within our case studies. We are thinking from a health psychologist perspective rather than perhaps a more clinical perspective here. But of course, we have something to bring as health psychologists to all of these, and many of us might work in settings where mental health is the primary outcome that we need to be supporting our patients with. But I think more the focus of our talk today is on how can we help people manage their long-term conditions in a more effective way in their community, as well as supporting the workforce to do that. Now, whilst I appreciate there's lots of health psychologists there, and I'm sure you know what you do, we've also got many more people by the looks of it in the audience who maybe aren't health psychologists, maybe have never met one, maybe don't work with one. So just so we're clear about what health psychologists do and our role, we are HCPC regulated health professionals and practitioner psychologists. So a health psychologist has to have an undergraduate degree in psychology, a master's degree in health psychology, and then a training route, either a doctorate in health psychology, which is similar in many ways to our other doctoral psychology routes, with practice and various other competencies that they have to acquire, or there is an independent training route through the British Psychological Society, where people are based in practice, often in the NHS, and they fulfil their competencies that way. So we typically have you know, an absolute minimum of about 7 to 8 years of training. For most people, it's much more than that, because obviously they need to gather experience in between those particular qualifications in order to progress to the next level. So for most of us, by the time we're qualified, we will have had a minimum of 10 years kind of experience in health psychology theory and practice. We are in the same box in the HCPC practitioner psychology box, as it were. We have many of the similar competencies, although of course there are some differences between what we're specifically focusing on, with counselling psychology, clinical psychology, forensic sports, educational and occupational. I almost forgot one there. And again, we have a lot in common, but obviously some points of difference. And our focus as health psychologists within our training is the theory and practice in understanding the psychological processes, understanding health and illness, in order to promote and maintain health, to analyse and improve the healthcare system and health policy formation, to help prevent illness and disability, and to enhance outcomes for those who are living with illness or disability. Now, I don't know about you, but in those previous slides that I've just presented, that seems to be quite a good match. There's quite a lot in there about helping people manage long-term conditions, preventing illness and disability, changing systems, promoting health. So my view is that we'd be great at helping and supporting the NHS, both at a local level, but also at a sort of national or regional level, in how to make some of these changes, these 3 shifts. We're trained in behaviour change. We're trained in psychological interventions, teaching and training, research and consultancy. Now, there are some differences. Our training doesn't typically involve working with people with severe and enduring mental health issues. However, we might be working with those patients alongside some of our clinical colleagues to help them with their health, for example. So we have experience in a wide range of areas, but our focus is physical health and coping with physical health from a psychological perspective, behaviour change and elements of mental health, but typically at a lower level than some of our psychiatric colleagues, some of our clinical colleagues. That's not to say many of us don't have lots of experience and further training in that area, but our core focus as health psychologists is in the things that are on the slide. Understanding health and illness, how people cope with it, how we might prevent illness and disability, and how we might enhance outcomes for those who are living with health conditions. So hopefully that gives you a little bit more of an insight of what health psychologists do. And of course, we're all different. So much like everybody on the call, we've had different career journeys and different skill sets. But our core business here is supporting people with their health and illness and preventing ill health and behaviour change. So if you'd like to know more about the sorts of things health psychologists do, there's a really nice booklet that the British Psychological Society Division of Health Psychology developed, which shows some career case studies from different people at different stages of their career. It probably is due an update. So this is 2021. So many of people have moved forward or become qualified or what have you since they did their career case study. But it gives you a really nice flavour of the wide range of areas in which health psychologists might work. And that's all on the slide. So we have expertise in, for example, diabetes care, many of us in sexual health, weight management, smoking cessation, stress management, drug and alcohol use, etc. And actually, for these reasons, growing opportunities for health psychologists in NHS practice was an aspiration of the workforce plan, the Psychological Professions Workforce Plan for England in 2021. So, going back few years ago, there was a recognition that health psychologists, weren't perhaps being offered the opportunities they should be within the NHS, and perhaps we should be, focused on improving that. That's been quite successful. It's approaching 200% growth according to the NHS employee returns. However, it's not as rosy as that. My graph there looks fantastic that we've kind of, more than doubled our number. However, in 2023, the ESR, there was a lot of focus on improving how the returns were made and making them more specific. And we knew that lots of health psychologists were being coded incorrectly already. So they were being coded as a clinical psychologist because they'd gone into a role that had been maybe originally advertised for a clinical psychologist, or perhaps they were coded in a more generic way as well. So our contribution was being somewhat masked by inaccurate returns. And there was a big push for all psychological professions, and kudos to everybody in psychological professions networks who made that happen and in their trusts. So we then had a lot better returns in 23-24. However, I think from the data, you can see that as well as that improvement in logging, there's clearly been a growth in the amount of posts. And obviously, even between 24 and 25 there, we can see that there were 6 more FTE equivalent posts in the NHS, which isn't loads, but it's clear growth even within 1 year. So we're seeing health psychology, we're seeing health psychology become more commonplace, and health psychologists more likely to be holding roles within the NHS, which is great news. It still leaves us in a very small group in many ways. And of course, the FTE is split. There's lots of part-time workers within that, and there's probably still lots of people incorrectly logged. But it does give us a sense that there is an improvement and we are becoming more recognised. So as I've said, current workforce estimates are quite inaccurate. And the contribution of health psychology and health psychologists is still underestimated, really. We know there's probably a lot more people out there than that doing this work. But we're getting there, you know, the picture's improving. I'd just like to make the point really while we're all together that there is much further scope to include health psychologists in NHS work to improve, you know, our practice. There's a lot of us on the HCPC register who are not working in the NHS. So again, whilst we're very small in number compared to our clinical colleagues, counselling psychology colleagues, for example, forensic, there is over 600 of us on the HCPC register, and that's growing all the time. And only about a sixth of us appear to be NHS employed. So there's a lot of knowledge, expertise that for whatever reason is not able to gain NHS posts or is going elsewhere. So where we might have a shortfall in the psychological workforce, I really feel that we could do more, perhaps, to bring our health psychologists into the NHS. We need more of us. And I've already said this, but let's underscore it because it's so important. We have the skills required of the 3 shifts. They all require workforce, patient and public, and systemic behaviour change and psychologically informed approaches. Who better than the flavour of psychologists who do a lot of behaviour change in our work and are trained to do so. So I think we're at the moment, you know, we could do more with our health psychology and our health psychologists. And I'm really, really happy we've been asked today to kind of showcase that. So I hope this morning will shine a light on health psychologists and how they're shifting NHS care from hospital to community. That's not all we can do, but it absolutely is a really, really good example of where we're already having lots of value. My 3 colleagues that are going to speak today come from different settings. They're all health psychologists. They're all doing different work, but it all has a really shared purpose of improving care for patients and moving care closer to where the point of need is. You'll see them talk about how they help people with long-term conditions and how they're using health psychology in a really positive way. So I'm really chuffed that we were able to bring such brilliant people together to have this conversation this morning. And I'd really like to thank them all for giving up their time for writing their slides and preparing their case studies, because I know they're all very busy off in their NHS trusts. So that's enough from me. I have noticed in the chat someone said, will the slides be available afterwards? And my understanding is yes, we normally make these available, potentially maybe even the recording, Sharon. I don't know whether you can address that in the chat with the question from Antonia. So I'm going to move on now to our first speaker, if they're available. And we're going to look at our very first case study. So welcome, Dr. Laurel Dismore.
Oh, thank you for that really nice introduction. Am I saying next slide, please, when I need you to move on? Is that what we're doing rather than me doing it?
I do think we're going to have to. We're going to have to do the. We're going to have to do the COVID style Chris Whitty, I think, this morning.
Yeah. Don't worry, I'm clicking furiously in the background to keep up with you all.
Brilliant, thanks, Kate. Hi everyone. So I'm Laurel Dismore. I'm a health psychologist working in research and development at Northumbria Healthcare NHS Foundation Trust. So my role is predominantly conducting research in the NHS and supporting our local investigators through the research pathway. But also I've worked more broadly looking at different projects of bridging clinical practice with research expertise. Most recently, I've been involved in a project where we looked into improving pathways of care for patients with persistent physical symptoms. So my presentation today will focus on living with and coping with PPS, which is a growing, challenging area affecting thousands of people whose symptoms often go unexplained, undertreated or misunderstood. So we're going to explore how we can shift the focus from hospital-based care to community-based and co-design health and wellbeing solutions, giving individuals more control and better support in their daily lives to enable wellness right where people look. So we'll have a look at the existing evidence around persistent physical symptoms and some of the main problems with existing care pathways, and how the work in the Trust in partnership with Kate at Newcastle University and our local primary care network have contributed to the evidence base. I'll also introduce the Core PPS project, and this is a NIHR Research for Patient Benefit funded grant. And this provides a really nice example of how collaborative approaches are hoping to make a difference on the ground with supporting the shift from hospital to community, and of course reflect on the role of health psychology has played in pioneering the work. Next slide, please, Kath. So persistent physical symptoms or long-term symptoms, it's a huge umbrella term to describe distressing somatic complaints regardless of their underlying cause that persist on most days for several months or longer. So these symptoms can be present in a variety of contexts, including somatic diseases, for example, fatigue and multiple sclerosis, functional somatic disorders, for example, diarrhea and IBS, and mental health conditions, things like headaches with people with depression, and there can also be an undiagnosed medical issue. Common symptoms often include general complaints like sleep disturbances, loss of energy, headaches, insomnia, and patients can also experience symptoms affecting specific systems. Next slide, please, Kath. So the presentation of PPS is associated with high healthcare utilisation and high costs, with around 20% of the global population experiencing symptoms and around 1 million UK adults. So this accounts for a substantial proportion of healthcare demand, making up at least 15% of GP consultations and between 30 to 50% of specialist referrals. People with PPS often end up in A&E and then spend more time as an inpatient. So you can imagine the impact on the NHS is considerable, and there's an urgent need to develop effective community-based solutions that better support individuals living with PPS. Moreover, PPS tends to be more common among people who've experienced adversity, underscoring the importance of understanding these symptoms in a broader social and psychological context. Next slide. Thanks, Kath. So what are some of the main problems when managing PPS? Well, one of the tricky things is that everybody experiences PPS differently, and we all use different words to describe how we feel, which can make understanding it really challenging. One big problem is that healthcare services often work in silo and are fragmented. So patients often get multiple referrals and lots of investigations and end up on a revolving door. So this is really frustrating and it's inefficient. And of course, it drives up costs for the NHS. But more importantly, all this contact with healthcare can feel really unhelpful and overwhelming. Many patients have a deep need to feel understood, but don't feel believed by friends, family, or medical professionals. And they're also caught up in searching for explanations for the symptoms. So often they can feel quite marginalised or left out of medical systems and are therefore left disappointed by healthcare. And this marginalisation is a real problem when there's no obvious way forward, as patients don't have a clear treatment pathway. Healthcare professionals face a lot of challenges too. There's things like diagnostic uncertainty, emotional strain, difficulties in communicating, and a lack of systemic support or training specifically for PPS. So there aren't enough specialist clinicians who really understand it. On top of that, consultations are usually time pressured, and clinicians might not always feel confident managing these complex cases. As a result, both doctors and patients can feel dissatisfied. Consultations can feel unrewarding for everybody involved, and sometimes dissatisfied patients seek more opinions or treatments that might not actually help. So in some cases, it can actually lead to complaints. Symptoms tend to get worse over time, and the healthcare focus often shifts on changing the person's health behaviours. But PPS is more than just behaviour. It's linked to mind-body experiences. It's this complex mix of biological, psychological, and then social factors all working together. Next slide, please, Kath. So with all this in mind, the Trust, in partnership with Kate at Newcastle University and the Primary Care Network, came together as a group to deliver 2 work streams to improve pathways of care for patients with PPS. So Kate and I co-supervised a trainee health psychologist to evaluate the current evidence and identify gaps through research and training of healthcare professionals. This included a systematic review to understand what psychological interventions were effective for managing PPS. And what we demonstrated is that psychological interventions have some success in managing somatic symptoms. However, their effectiveness for other psychological symptoms is mixed. We also conducted a second systematic review to identify current clinical skills development for healthcare professionals working with patients with PPS. Various training programs focusing on improving clinical skills specifically for PPS consultations, emphasise that communication-based training helps clinicians take an holistic approach to explaining symptoms using a biopsychosocial model. So from the evidence, a series of clinical skills workshops were hosted by the Trust. So we trained healthcare professionals in having psychologically informed consultations, and these have now been published as e-learning modules. Training healthcare professionals improves patients' outcomes. It can result in fewer visits to GPs and specialists and it increases clinicians' confidence in managing PPS. But despite these advances, challenges and costs related to PPS remain significant, suggesting current needs are not fully being met. So this opens opportunities for community-based initiatives. We also interviewed healthcare professionals on their experiences of providing care and patients' experience of current care pathways, and they also agreed that there's a role for community-based support. So I suppose the big question now is, how do we do that? Next slide, please, Kath. Okay, so let's shift the focus from the clinical setting to the community, because most people living with PPS spend most of their time outside the healthcare system. Many people do develop strategies like pacing their activities, changing their routines, seeking peer support to manage symptoms over time. So this raises the question, what community resources are available that could support people living with PPS? This might include things like community groups, peer support networks, voluntary sector organisations, mental health charities. We can link in with social prescribers and any local wellbeing hubs, because these resources can play a vital role in reducing isolation, improving wellbeing and supporting meaningful activity and identity. But we also need to ask, are healthcare professionals working closely enough with these community colleagues? Just go back for me a second, Kath. And often the answer is no. So there's a gap between healthcare and community services, and people with PPS can fall into that gap. Healthcare tends to focus on diagnosis and treatment, while the community offers support with day-to-day living and identity. So we need better integration between these two areas. And finally, and perhaps one of the most important questions is, how might we all work together to do something differently? So how can we co-create a system that supports people more holistically? That might mean training for both clinical and community professionals, shared care planning, better signposting, and really valuing the expertise of people with lived experience. It also means changing how we might think about health, not just the absence of illness, but the ability to live well despite symptoms. So if we want to improve health and wellbeing for people with PPS, we need to step outside of traditional models and collaborate across sectors, making sure that the community is at the heart of the work that we do. Next slide, please, Kath. So those questions is what brought us to the Core PPS project. So we're working alongside our stakeholders to improve ways of living with PPS in the community in areas with the greatest health inequalities. This involves insights from those with lived experience and a collaborative approach to make sure that we're actually making a difference on the ground. So I've been involved in several patient-public involvement sessions with the local communities that we're working with to make sure that we're including members of the public to identify gaps in provision and drive changes going forward. And we have the privilege of Sam, who's joined the session today, who runs a fibromyalgia and chronic pain support group in the community. Sam's working closely with us to deliver the project and is representing her local community. So while this work is part of a research project, it's important to emphasise that we're taking a co-production methodology and work with multiple agencies to co-design solutions based upon the community's needs and priorities. Next slide, please, Kath. So this project, what you can see now is what we call an infographic. So it outlines our work package 1. So the project will be delivered through 3 work packages. In the first stage, we'll explore what it's like for people in day-to-day living with PPS, what helps them feel supported. We'll then map out the local support to uncover who, what and where matters for people and identify the current gaps. And then finally co-design potential solutions and make some recommendations. We're also interested in the language used to describe PPS and also how do people transition from hospitals to the community and what's really driving that behaviour. Next slide, please. So gathering data through qualitative interviews is great, but additionally, we've applied an innovative ethnographic approach, capturing data using local walks or visits to places that are important to people. This might be in the garden or in the home. As going to see examples and details helps us understand the problem that people have to deal with, so we can work on them during the co-design of solutions. So showing the research of their world, as often it can trigger further insights, and these are called go-along interviews. And my last slide, I think, is coming up next, please, Kath. So thinking about particularly the role of health psychologists, so the work's been grounded in the scientist practitioner model, really bridging clinical insight with research expertise to ensure that interventions are evidence-based and effective. So this means we know we're not just applying theory, we're continuously evaluating and improving practice based on the latest science. A key part of our role has been training healthcare professionals to use the biopsychosocial model when working with PPS. So while it's been implemented in a hospital setting, there's now a real opportunity to expand this approach into the community, helping clinicians and support workers to view symptoms holistically. But to do this, it's important to build strong partnerships with community teams and collaborate with social prescribers and local coordinators, because these professionals can increase access to link workers who connect people with non-medical community activities and support services, which is really crucial. So we listened to communities, we understood their unique needs and priorities, so we've embedded patient and public involvement throughout everything we've done, and we'll continue to do that. And beyond direct care, we can raise awareness of PPS by advocating for the inclusion of it in public health policies, maybe look to develop some helpful educational materials for patients, clinicians and communities on understanding symptoms and the biopsychosocial nature of symptoms. And that's the highest symptom improvement and lowest persistent rates have actually been shown to be within specialised care settings as compared to primary and secondary care. So by working across these areas, we can support healthier communities and improve quality of life for people living with PPS, and hopefully extend that to long-term conditions. Thank you.
Thank you so much, Laurel, for that. That was amazing. Because we're kind of short of time, we'll definitely keep questions for the end. So if I move on and introduce Dr. Matthew Cooper. Matt, I'll let you introduce yourself to everyone and just tell me when to click on. I'm champion IT person today.
Brilliant. No, thank you. Yeah, and hi everyone. It's nice to actually see so many people on the call. So it's great to have this kind of involvement already. So yeah, as already said, I'm Matt Cooper. I am a lecturer in psychology at Newcastle University, but also a researcher in our patient safety research collaboration. But crucially for this, health psychologist, obviously from the BPS. Next slide, please. Oh, there we go. So all of my work kind of stems from understanding how we can ensure healthcare into community settings, and obviously this has been going on for a bit longer than the announcement of the 10-year plan. But my particular areas of current research, particularly with health psychology, centres around transitions of care, ensuring that not only we're talking about health as a kind of physical thing, but that we've got mental and social health in there as well. So really bringing together a lot of different services and providing that kind of holistic support. And so for me, health psychology has been paramount in understanding that effective transition between different settings, and actually, you know, the NHS 10-year plan is great to kind of reinforce some of this work. But actually, I think health psychology is going to be the driver, as we've already heard, in actually the practicalities of how we shift this across. So next slide, please. So I'm going to talk you through a couple of kind of case studies where I've kind of been using my skills in health psychology and to work with colleagues around understanding really where health psychology can benefit the development of these different settings. So the first one I'm going to talk about is around a cardiovascular disease clinic and looking at a kind of a disease screening platform and how health psychology has kind of really supported that development. And then I'm going to talk a little bit around workforce development and around actually some of the points that have been mentioned already, but particularly around using how we can understand individuals in a kind of group setting and how we can build communities to better kind of accept the healthcare that we're going to take forward. I also just want to mention as well that there is lots and lots of areas that I think health psychology is really important, particularly around healthcare. And working with various organisations, authorities and integrated care boards, but also different NHS healthcare professionals, and really trying to understand the mechanisms behind behaviour change. And I think that's really been crucial for the work that I've been doing, is almost selling the benefits of health psychology when possibly different areas where we've not already done so in the past. Next slide, please. So the first example I'm going to talk you through is what's called the Young at Heart Clinic. And so next slide, please, Kate. So the Young at Heart Clinic, for those who aren't based in Newcastle, we have what's called the Granger Market. And the Granger Market is in our kind of central city centre. And it's a really kind of popular, I think it was originally established in like 1805, I think. But it's kind of a lot of diversity in the people who are attending. It's a kind of closed market where it has lots of different food vendors, lots of different kind of shops and stalls. And we've got the clinic based in there because of the diversity of the people who come through. So it is a really popular space. But we've kind of taken healthcare into the community already, and that was established in 2019. It's a student-led clinic. So this is with our pharmacy students who go out and they deliver what is more broadly possibly known as the NHS health check. And so since 2019, they've kind of done over 5,000 health checks with members of the community who wouldn't have accessed NHS health check services in any other way. So typically there's lots of reasons why people don't take up an NHS health check. But a lot of the time it's because of, practicalities. They're scared of opening, typical NHS letters, and actually having it in the community has been really important. To kind of bring that healthcare into that setting. So the health check, as some pictures represent there, that the health check is basically, it goes through some clinical measures. So that's blood pressure, blood glucose, height, weight, cholesterol, and we're now looking at a couple of different tests, but particularly it focuses on lifestyle factors. So it will ask individuals around their diet, around their physical activity, their smoking, their alcohol intake, and then also about their well-being, and really looks at identifying where current lifestyle behaviours might affect their cardiovascular disease risk. So particularly, this is a lifestyle screening tool. It costs the NHS around £75 million a year to run, and it is really good at identifying cardiovascular disease risk. The bit it's not so good at is once that risk has been identified, then doing something about it. And so for me, this is where health psychology is really the black box thinking around, someone's been given, an increased risk of cardiovascular disease. Now what? And actually, this is an area that I've been working on quite a lot in the last few years, and developing this kind of brief behavioural intervention. So instead of, you sat there and going, in the next 10 years, or this is kind of affecting your cardiovascular disease, off you go. Can we support an individual then to start looking at potentially what are those risk factors? Where are areas that they feel are tangible changes that they can make, and then support someone to make those changes in their behaviour? And I think this is where health psychology is being applied in a really effective way. I've been working with the clinical supervisors and with the clinical team to really get them to kind of start thinking beyond those immediate clinical measures and immediate clinical outcomes, and start thinking about that individual in front of them, and start using some of the behaviour change theory that we have in health psychology to start to understand where they can better support those individuals in the right way, in the way that means something to them, but also within their own community. So, for example, it might be, they will be able to motivate someone to go along to a stop smoking clinic, or it might be that they work on developing the opportunities around, increasing their physical activity, and actually being able to have a kind of informed conversation with someone supports that brief behavioural intervention. So they're not just given, a risk to a patient, but they're then actually working with that patient very briefly to then build that onward support going forward. And I think actually from a health psychology perspective, there's a lot more where we can be doing this with other areas. We obviously just heard of one just before there. But actually, I think as we shift to community, the connection between the two, and particularly around physical, mental, and social health, we're kind of bringing this together. And I think that's where health psychology is really effective in understanding those individual level factors and how we can better kind of support that going forward. If we flick to the next slide, please. And so the second example kind of builds on that, and it particularly builds on the next presentation. Sorry, the previous presentation, as it was almost as if we planned it. Next slide, please, Kate. In talking about workforce development, so particularly for me, this is around social prescribing. And so I've probably been researching and developing social prescribing for probably the last 10 years or so now. And so I think this particular example is really prominent with the 10-year plan. So the diagram you see on the left of your screen there is kind of my map of what social prescribing currently looks like in England particularly. And so it's currently offered through primary care within kind of NHS models. And that person kind of can present at primary care for any reason at all. It might not be a mental health reason or a social health reason. It could be a physical symptom that they're kind of having difficulty with. And if within primary care, whoever they see deems that actually they could do with some community-based support, they can be referred to a social prescribing link worker or a social prescribing service, which are embedded in communities. And this for me this has been happening since 2019. This is a model. And so we've already been trying to kind of build that collaboration between healthcare and community care. And actually, it's a really nice example of when this does work, and it has worked really well. And so, as you can see, that patient kind of works through the flow where they will present at primary care, or they can self-refer into the community social prescribing service. That social prescribing service and link worker can work with that individual on what matters to them and what matters to them within their community. And it can be that, you know, there is options and there's different services, how they deliver that support, but typically it's all community-based support. And as time's gone on since 2019, social prescribing has been able to develop community resources. So that's the other key thing, that if we think about the 10-year plan, there is that development that goes through both the flow of patients, but also in terms of that development going forward. And actually, as it's just popped on screen, for me, this is where health psychology was really important to develop that consistent flow of information, but also that consistent message in how we're trying to support patients going forward. So using the COMV model, which is on screen, so that's capability, opportunity, motivation leads to behavioral intention, and actually being able to have that informed conversation around how individuals as healthcare providers can support that individual going forward. So, sorry, Kate, can you jump back a little bit before I jump onto that next bit? So really, social prescribing is great. It is currently, you know, it's not something that's new in concept. Actually, if you we look back to when the NHS was originally conceived back in 1948. This was a typical kind of plan that the NHS was going to follow. So we're almost kind of doing a little bit of a circle back around to what it was going to look like. But from a health psychology perspective, what's really important is that the emphasis is on supporting that individual in their management of their conditions in the community, and actually being able to work with an individual across a system is great. The problem that we have, however, at the minute, is that this is a very medicalized approach. And a lot of the time we are looking at medical outcomes, we're looking at clinical prescribing, we're looking at clinical flows of patients that sometimes create difficulties in the community. Next little click, please, Kate, to bring that up. So this is where what we've been doing from a health psychology lens is been really important in looking at patient safety and patient harms, and actually trying to use some of the language around the clinical and medical terms to be able to support communities in that connection. So not only are we working from the NHS outwards, but we're working from communities inwards as well, and really developing that common framework and that common language. Another click, please, Kate. And so what I've been doing is working a lot with social prescribers in the community. And so this is where we have been working around supporting them understanding health psychology, understanding about the theories and principles that we can apply, but really around developing that shared language and that shared communication around the approach that both primary care is being taken, but also that the community is in developing that. So that patient doesn't have what has happened in the past, where they get one thing from one person, one thing from something else, and then really what they want is somewhere in the middle. And so actually from a workforce development point of view, it's been really important to have that alignment with the 10-year plan, but also that two-ended approach in development, and that actually that understanding about, as you know, from a health psychology perspective, what we can offer is supporting them understand how to support that individual, and ultimately everyone's in that role to support an individual. And actually this is where health psychology is being great at providing that link, in that I call it the kind of black box thinking, in terms of understanding how to support that individual better, but also having that influence on the system, on the organisation, and then on the workforce, and being able to deliver effective change and support that sustainable behaviour change across the shift into the communities. And this has been working really well. I currently do a lot of training with the link workers in the Northeast, and work alongside kind of developing this practice and as a service as we shift more into community. And I think it's really important actually that as we are moving to community, there is that shared understanding development of the kind of how health psychology can support that shift, because that shift sometimes can be uncomfortable from a patient perspective. If, you know, take, for example, a little bit of work linked to the cardiovascular disease screening clinic, is that the shift to having MRIs and CT scanners now in the community, and we work alongside those community programs. So again, for those not in the Northeast or Northern East very well, we have the Metro Centre, which is quite a large indoor shopping centre, and we have a clinic based in there, which is next door to the community screening. And that there is a unique opportunity to provide screening within the community, but actually that shift is sometimes a little bit uncomfortable for patients when they are turning up to get an MRI scan next door to the place that they will then go and do their clothes shopping. And actually trying to shift that narrative and that understanding is where health psychology, I think, is going to be absolutely pivotal in supporting that change. Yeah, that's all I was going to say. So I think that's the end of my slides. So thank you very much.
Oh, thank you so much, Matt. We'll probably have a couple of questions for you at the end. I'd like to hand over now to Niall, who will tell us about a pilot diabetes psychology service in Derbyshire. Niall, tell me when to click.
Perfect, thank you. Hi everyone, I'm Niall. I'm a consultant health psychologist working in Derbyshire. I'm really delighted to be invited along today and talk about an area I'm really passionate about, which is working with people and services living with long-term conditions. I'm based in Derbyshire Community Health Services, and we're really fortunate as a department that we've got a brilliant skill mix. So we have several health psychologists, clinical psychologists, CBT therapists who all work in different areas, and really importantly, we have much more in common than we have different, but we all have different skills and experience that I think can really add to kind of working in long-term conditions. And I'm going to talk about a specific project that I was working on last year relating to specialist diabetes, and I think it really showcases the shift from hospital to community. Can you skip forward 2 slides, please? So I'm going to talk about what the problem is first. So for people that don't know, so diabetes is a term used for a group of conditions where effectively there are difficulties with the pancreas. People will probably be quite familiar with type 2 diabetes, which makes up about 90% of people living with diabetes, where people's pancreas, the insulin that they produce in order to break down sugar in food, becomes less effective over time. Historically, type 2 diabetes was thought as being something which is purely related to behavioural factors, but we know it's about 70% genetic, and that certain groups are more likely to develop it. And we know that particularly when people develop it young, that can have really significant challenges. About 9% of people living with diabetes have type 1 diabetes, which is an inherited condition that involves injecting insulin and monitoring your blood sugars all day, basically, which is really, really hard to live with. And there are 1% of diabetic conditions are made up by other types. We know diabetes is really expensive, so these figures are a little bit old now, and they've actually grown since the latest studies, but about 6% of the entire NHS budget is spent on diabetes. And we know that about 60% of that is on complications. So with the kind of what's been said about health psychology and the role we can play so far, I think it's quite clear the role in terms of reducing this. And we know that difficulties with self-management increases cost. So an increase of about 11 millimole or 1% cost 4.4% more. So can we go on to the next slide, please? We know living with diabetes is really hard, actually. So 1 in 3 people living with any long-term condition live with a comorbid diagnosed mental health condition. And the key word here is diagnosed, because we know 3 in 4 people who are diagnosed with diabetes are likely to experience an increase to their anxiety or their depression symptoms. And really importantly, we know if people have pre-existing mental health conditions, they are much more likely to have worse health outcomes, engagement with healthcare, and increase the cost. Attending appointments could be really, really difficult if you've got long-term difficulties with depression or historical traumas, for example. Next slide, please. We know that specialist psychology input can make a difference. So there's very few services across there in the NHS, but we know that if we're able to reduce people's blood sugars, we're able to have an improvement. So we know that a Hillingdon Wellbeing service, which was a psychology-led service, reduced costs by about 34% in a 12-month period for people who are working with. And if everyone was offered it, was estimated that it could save over £500,000. So a huge amount of money could be saved by putting psychology in. Next slide, please. So if we know that it can be effective, what's the problem? Well, services haven't historically been developed necessarily with the needs of people, the kind of biopsychosocial needs in mind. We know that physical health services and mental health services historically have been developed separately. So if people have diabetes, they're seen by physical health clinicians and they receive support for that. And if people need it or they're lucky enough to receive it, they may see consultant-led services. If people generally have difficulties with their mental health, we're much more likely to be seen in the mental health pathways. So for the majority of us, that would mean NHS talking therapies, which we know the evidence is there that CBT for depression isn't effective for people with long-term conditions unless it's specifically tailored. And we know that community mental health services do a really good job with people with complex mental health needs. But in terms of tailoring that for diabetes, that can be really difficult. We do know there are some clinical health psychology services out there, but often it is variable depending on the area that they're based in. They are often hospital-based as well. So in terms of the shift from hospital to community, that's going to be an increasing challenge going forward about kind of how is that managed when actually the services are funded from pretty limited pots within the physical health pathway, very specifically relating to hospital. Can we skip forward, please? One more slide, please. So I'm going to talk about what we did in Derbyshire. So I'm based in Derbyshire Community Health Services. So we cover the whole of Derbyshire, which is this patch here. We have quite an interesting setup in Derbyshire because we don't have one acute trust, we have 2. So we have Chesterfield Royal Hospital, which is in the north of Derbyshire. We also have Royal Derby Hospital in the south. But we also have lots of people, because of our geographical kind of area and setup, who access specialist care outside of Derbyshire. So we have lots of people, particularly in the east, in the high peaks, which who might go across to Stockport, or people in the west who go to Stockport, or people in the east who go to Nottingham, for example. So we have lots of people within our ICB who see GPs in Derbyshire who don't access specialist care. So again, it's another reason that community-based services can be really, really important. Skip one slide, please. So what we did was we took an innovative approach using DCHS, which is a community health service, as the host organisation to work with people living with complex needs and predominantly type 1 diabetes across the county. This involved working with services, so co-designing with the hospital, with community services, GPs, NHS talking therapies, to agree on the pathway, processes, and what we offer. We combined providing clinics in acute, community, and remote settings, and we did clinical and indirect roles. So can we skip forward one more slide, please? So in terms of what this looked like in practice, I know this is a busy slide. It's very hard to break down into a small amount, but this involved kind of Derbyshire-wide leadership. So this involved being involved in diabetes steering groups, case consultations, and teaching and training with staff across the patch in order to upskill people and really advocate for psychology in that pathway. It involved working with physical health systems, so running clinics and embedding within both Chesterfield Royal Hospital and Royal Derby Hospital, but also with GPs and nursing practices in the community. It involved liaising with those in mental health systems, so NHS talking therapies, community mental health services, but also liaison services for people who might be presenting with risk, but not necessarily hitting the criteria because it was diabetes related. And we did a combination of approaches, so acute-based, community and remote services, providing short-term, medium-term and long-term psychological interventions tailored towards the needs of the individuals. Can we move one slide, please? And one more slide, please. So I'm going to give one case study of what this looked like in practice, because I know that can feel a bit kind of theoretical. So I'm going to introduce a gentleman called John, who is a male in his late 20s. He was diagnosed with type 1 diabetes as a child and had never really accepted or kind of come to terms with his diabetes. So he was a high-intensity user, so he frequently attended A&E and high-dependency unit, didn't have any routine of insulin or meals, and that's why he continually was attending A&E. He had limited family support, his history of kind of family health difficulties, not really accessing healthcare, a history of mental health difficulties, so that's kind of all he'd really known, and really didn't engage with the diabetes team apart from when he came to A&E, went to the high dependency unit, and then was discharged again. So he had really long-term difficulties with low moods, diabetes-related distress, and low quality of life and well-being. Didn't really see much point in things improving. Can we skip one slide, please? So what we worked on is we did 8 sessions of cognitive behavioural therapy tailored towards low mood relating to type 1 diabetes specifically, and focusing on improving that insulin relationship and self-management. By the end of our work together, he had improved his self-management, so he was having 2 meals a day and injecting insulin. His HbA1c within 6 months had improved by 45 millimoles, which is a really, really significant drop. It was about a third from his original high level. And really importantly, over 7 months, he had no A&E or high dependency unit attendances. So this improved productivity. So he was engaging with the team better, but actually needing to use them less. So he was being seen in the hospital less and engaging much more with community services. He was actually doing what mattered to him, which is really important. So making plans to enhance his quality of life. And really importantly, he felt he had the tools to kind of cope moving forward. So it wasn't just a short-term shift, it was a longer term. Can we skip forward 3 slides, please? I'm going to skip the next case study. So really importantly, what did this mean for staff? So staff in hospitals felt like it was effective. So all of the staff that we surveyed said that they wanted it to continue. They saw the benefit of that diabetes is a chronic long-term health condition that people have to live with. And there is a health and health economics perspective that this was really positive. People recognised the fact that actually they had their role in the hospital, but we needed to look beyond that into the community and how are people being managed elsewhere. And really just the acknowledgement that living with diabetes is really, really difficult and we need support as well as the individuals. Next slide, please. In terms of the ability and knowing who to refer to. So before we looked at kind of capability, opportunity and motivation for being able to make referrals onto appropriate services. So when people are faced with this in the hospital, how do they access that community-based support? And even though NHS talking therapies and community mental health routes were there before, we were able to increase all of these kind of factors in terms of the ability, capability, opportunity and motivation to support people to access that support. Next slide, please. Staff felt that we actually had an impact. So really importantly, they felt there was some benefit to these existing services, but often they were saying, well, we're not referring because we don't think it's going to improve diabetes, adherence to medication, reduce attendances. So all of these factors, again, staff were saying we felt there's a really significant improvement in terms of what's going to happen, which again, if we're able to do that, that increases motivation to refer on. Next slide, please. In terms of what changed for patients, so we had really, really good feedback. We don't have time to go into kind of the qualitative stuff today, unfortunately, but in terms of the medical management, which is really important, if we are going to shift care from hospital to community, we need to know that people are being managed safely, that their health outcomes are appropriately being managed out in the community. And we saw within a very short period of time for the data we're able to access that there was improvement in the kind of 3 core measures for diabetes, which are diabetes control or HbA1c, blood pressure and cholesterol. And this is for people experiencing really complex needs. So they've been working with these teams for years and years and years and not having these sort of benefits. Next slide, please. Obviously, we're talking about psychology perspective, so it's all very well and good managing one side of things with the physical health, but if we're not improving the mental health side of things, we're kind of missing part of the picture. So we saw there's improvements to psychological distress, quality of life and daily health ratings, but also in diabetes related to stress. So again, this wasn't kind of short-term improvements people are experiencing. It was actually, if we're able to support you at this part of the chain to move you further into the community, this can have really, really significant benefits in terms of the implication for that. Next slide, please. So what our key learning from this was that diabetes psychology, and I would say that while I've spoken about diabetes psychology, diabetes isn't alone. You know, a lot of the kind of health beliefs and the difficulties that people might experience are shared across health conditions that might also not have access to specialist psychology support. But we know that if these services exist, the need is there. People want to use it, staff want to use it. We had to stop accepting referrals because of the very limited time frame that we had and the capacity. It was just me, you know, the whole time equivalent, kind of working in the service. We had to kind of cap who we could see, what we could see, but we know we could have had, you know, a lot more referrals. We think that diabetes psychology effectively moved care away from hospitals to community. By engaging at different parts of the chain, we are able to support staff working in hospitals, but also work alongside NHS talking therapies, community mental health, GPs, etc., in order to kind of keep people out in the community, engaging appropriately when they need to with the hospital, but reducing that kind of high dependency in A&E. And really importantly, if we don't have these sort of services, the need is still there. It will exist because we know this need was there. We've been told for years in Derbyshire that we need this special support and we've not been able to access it. So what we've shown is that actually when we implement these things, the need exists and it will improve things. But if we don't, we will keep the pressures in hospitals. A big difficulty with where we're at now and kind of the shift from where we are and where the NHS 10-year plan wants us to go is there needs to be changes to the system in order for that to happen. If we don't have kind of significant change, we're going to keep this pressure in the hospital. So we do need to move things, but how do we do that? And I think health psychology and clinical health psychology is a really important role to play. Can we skip forward 2 slides, please, to my final slide? So I guess what now is the question. I'd love to be able to say that this pilot project was kept on, that we got lots of funding and that things are going from strength to strength. But unfortunately, with the project ending in April, just before the 10-year plan came in, it was probably the most difficult time for us to be applying for funding, because what we're hearing from the acutes is we have no money to fund this, which, you know, given the changes to their climate, and because of uncertainty about NHS England and kind of funding going forward, we haven't been able to secure funding. So despite all of the positive improvements that we've been able to demonstrate within this, we are at crossroads here. So I think from my perspective, what I'd be pitching is that if we do want to make this change, if we do want to make this shift from hospital to community, then really difficult decisions have to be made. And with clinical health psychology and health psychology's role kind of in this middle ground where we don't receive funding necessarily from mental health pathways, and we're kind of scraping around for funding in physical health pathways, I think the really significant shifts need to be made. And I think some of the key areas that Liz pointed out earlier on about some of the funding priorities going forward, I think we need to factor in kind of what we can do and what we know the evidence is. So we are at crossroads. I do think it's a really good opportunity going forward for things to change and things to improve. And hopefully Derbyshire will show that going forward. So thank you very much for the opportunity. It's been a pleasure.
Oh, thank you so much, Niall. I think everyone will agree, 3 absolutely amazing, but very different kind of case studies, but yet all showcasing the work of health psychologists within the country. So thanks so much. I think we'll maybe take a couple of questions. Sharon, I noticed you had a question in the chat around for Matt. Are there any outcome data for the Young at Heart project?
Oh, yeah. Oh. Sorry, that the little thing had fallen off. Yeah, so we have actually, and so particularly around what we've been really successful in is we've been able to access those in the most deprived IMD deciles within our region. And what we did in terms of an evaluation we've just finished, the kind of outputs are still getting prepared, is that we looked at a 2-week follow-up, a 4-week follow-up, and a 6-week follow-up, and looked at behavioural intention and looked at the changes that have been made during that period of time. And actually, we've got some really strong data to say that even a brief behavioural intervention at, you know, the point of results has had lasting impact up to 6 weeks post screen. And in terms of the types of organisations that people have then had referrals onto, so particularly around there is a couple of different kind of real main ones. The follow-up with a GP is particularly around those who've got really high blood pressure, and that conversation around statin, that is almost always immediately followed up, and obviously there's practical reasons why that's been the case. But actually what we've been really strong at following the kind of brief behavioural intervention is being able to provide kind of onwards referral to smoking cessation, physical activity. And actually the next point of the evaluation that we want to do is to start measuring actually watch someone have a bit of a control group of those who have the behavioural intervention and those don't, see what the kind of differences as we go on. I will also pop in the chat a animation that we have, which gives the kind of a bit more overview of the Young and Hot clinic, and it touches on some of the outcomes that we've also got. But from a behaviour change point of view and a health psychology point of view, we kind of know that we can change someone's behavioural intentions up to 6 week post, which has been super interesting. Yeah, if that doesn't answer your question, give me a shout, but I will try and I'll post the link to the animation as well.
It's brilliant. Thank you. Absolutely brilliant. Really impressive.
There's a question in the chat around from Darling Duffield that's just popped in, Kate. I don't know if do you want me to read it out?
Yes, please.
Lovely. So Darling said you've referenced deprived areas several times with a shift from hospital to community. How do you think the challenges are managed in the potential inequality of services provided in the community, both from NHS services and the third sector, both on a national and local level? And I think that's a really good question, isn't it? This sort of health inequality issue is something that we think deeply about as health psychologists, isn't it? And how we meet the needs of our very diverse communities. I don't know if anybody wants to take that, who might have mentioned that in their talk, or...
So I obviously have just mentioned it there, so I possibly will go first, and just to kind of let others think a little bit. So yeah, and I'm just looking at your question again in the chat there. I think inequity of services and inequality of services is really important, but I also think that there's possibly an understanding about the different sectors and what that means, actually what inequality and inequity of service means. Because how we design service and build services should be fundamentally from the ground up about reducing inequity of support. However, if you look at communities and just think about, for example, geographical spread. So again, from my experiences, we've got kind of coastal towns, we've got very isolated rural towns, and how equity and inequality looks in those spaces compared to a city centre, in terms of just geographical location of services, that's really important. And so I think I referenced about deprived communities because of that's the kind of, the IMD deciles and the things that we've looked at. But actually, I think how we address inequity and inequality will change depending on the type of question that we're asking and the support and services that we're working with, because that is fundamental to how healthcare will shift within the community. Not every community will be the same. Not every need will be the same. And so defining what we mean by that, I think, is possibly the first bit for me. And that's the big challenge.
I read a really good piece by the King's Fund specifically about the hospital to community shift. And I really liked, I can't remember who the authors were now, but I really liked a phrase that they used, which was, we can't just talk about community as in neighbourhood based, it needs to be neighbourhood led. And I think there's been a lot of discussion about situating neighbourhood hubs or support within the community, but not so much about co-production and really having involvement and engagement, and that those other bits of the combi model need to be in there as much as the physical opportunity needs to be there. And so I'm hopeful that will come with time when we look at more of the detail about how hospital to community is going to be rolled out. But I think if we're going to tackle inequality and need within our diverse communities, and as you say, very different rural and coastal versus some of our city-based urban spaces, we really need to be thinking about how this can be led by the community and owned by the community rather than simply situated within the community. I think that's really important. Niall, you had something to say.
Yeah, I think it's a really important question, and I think in the long-term conditions kind of sphere, I think it's a really good example, because in order to be seen by specialist medical clinicians, you need to go to your appointments. They need to be accessible. You need to feel like there's a benefit and they work for you. And same with kind of traditional mental health services. Ultimately, you need to attend appointments, they need to be accessible for you. And I think what we find in Derbyshire, because we have quite a large geographical patch with, quite different in areas. We have, for example, in Derby, where there are lots of groups from different ethnic, cultural, religious backgrounds. We have certain areas of Derbyshire, particularly in the High Peak, where it's very rural, quite high levels of poverty in some areas. And what those communities need is very, very different ultimately. And I think we've developed services based on a model of we deliver it and you come to us. And I think what could be really positive about the 10-year plan and this kind of move towards neighbourhood hubs and is that there's an opportunity there to, as we say, kind of co-produce and co-design and involve people in what do you actually need. Because I think, for example, inner city Derby versus Buxton, very, very different needs that they will have. So I see it as a real opportunity, but I think it's one of those things that needs to be done fully rather than kind of tokenistically, because I think there is an opportunity. And if we just kind of copy and paste and then, as Liz says, kind of go, right, we'll do that there, it's based there, we'll do that there, it's based there, we're really missing this opportunity. So yeah, really big problem, but also really big opportunity, hopefully.
Thanks. Yeah, and as you said, Matt, in the chat, we need to think community in terms of cultural, religious, all kinds of overlapping ways that we could, and intersectional ways we could think about being based in a community that perhaps at the moment there's limited detail on in the plan, and we hope that will come with time, but really important things to think about. There's been a question in the chat around your talk, Matt, and mentioning brief psychologically informed behavioural interventions and whether you think they might be linked to the new emerging Band 4 health coaching roles. I don't know if you're familiar with those or anybody is familiar with those.
I'm not familiar with the new Band 4 role, so I don't think I could comment directly on that. I don't know if anyone else is, though.
I can give a bit of context, which is
the
ICB in Devon sort of promoting a model which is tripartite. So you've got a care coordinator, a health coach who's trained in really basic level behaviour change, including the combi, and a social prescriber, and then they work together.
Right.
Okay. Yeah, so I guess it's an additional role that's come in a line, and again, this might be really specific, but is it in line with where a social prescriber currently sits at the level in primary care? Is that the question? Sorry, I don't think I quite get your question, James.
It is in line with the social prescriber, the role. The question is just about what your behavioural intention was. It a psychologist who was delivering that, or was it a Band 4 position that was delivering that?
Yeah, thank you for that clarity. Yeah, so actually we have got kind of a two-phase model. So because this is a student-led clinic initially, they are pharmacy students, and then they have clinical supervision from pharmacists. And so actually they are pharmacists delivering this very brief behavioural intervention. And actually that links into particularly around the job description of a pharmacist, because within a pharmacist role, they have the particular medications, they have all the patient safety, they have all the community approach. But when a pharmacist is embedded in community practice particularly, they have a role of delivering public health and working with the communities that their pharmacy is embedded within. And so what we've kind of found, and I'm coming from a pharmacist kind of role because I currently work within the School of Pharmacy as well, is that providing pharmacists with the skills to be able to have those conversations not only supports their pharmacy medication management, medication review delivery, but also embeds them in that community approach. So when I talked before about having that NHS down and community up, the kind of student-led approach is that those students will then go and work either in hospital pharmacy or community pharmacy and continue that agenda of thinking about communities and that connective shared language. So at the minute, James, yes, they're pharmacists delivering this. But then if I think about the workforce development work that I've been doing, they're with social prescribers. So if they're on the equivalent, it would be that same level of that they are trained in that basic understanding and that basic approach, but under that supervision of a health psychologist to be able to support them in things where they're struggling. And that sounds like the model that you've mentioned there. And so it kind of mirrors that in a couple of different ways.
Thank you. That's really interesting. And I'll pop a link in the chat just for anyone who's interested in those emerging roles.
Please do.
I think that would be really interesting. There's been a lot of the new roles, hasn't there, in the psychological professions and in health and healthy lifestyles. And I think for us as health psychologists, it's really interesting to see that there are kind of lots of things popping up that are often at that lower banding than our maybe training health psychologists and beyond. And again, it's our role perhaps to maybe help train those professionals as well in more psychologically informed approaches to what they're doing. So yeah, really interesting to see how many new roles are coming up and coming through. Brilliant. Sharon, you've got a question, and we've got a couple of minutes left, so I think we've probably got time for it.
Thank you. And I think it might be a nice one to end on, just an observation about, I was really keen to have the talk today because to think about the role of health psychology in neighbourhood hubs and building capacity within communities. So something about, how can we support other roles and other professionals to support healthy lifestyles. And there is something, I think, about how we build capacity within other roles and communities, how we think about implementation change within systems, because it made my heart sink, I think, as it Niall, I was thinking, I know how this story ends. And you know how it ends. It's a beautiful innovation, and yet we have wonderful pilots, and then there's no money. So something I think about us as system as senior leaders, what can we do in terms of promoting and getting the message out and being strategic and positioning ourselves at various boards and the relationships that we have, etc., etc. So I think this has been a fantastic, sorry, it sounds superlative, but blown away. And it's absolutely brilliant, the work that you've showcased here today. And I'm just really keen to think about how we can kind of shine a spotlight on what you're doing and promote the work, particularly around this agenda. I think we miss a trick if we don't.
Thanks, Sharon, and thanks for inviting us. You may or may not know Sharon's been a great advocate for health psychology in her region. And one of the roles I've been doing over the last few years, although that's coming to an end with NHS England changing around, disbanding, has been as a health psychology lead in NHS England, and Sharon's been a real support there in the region, as have many of the other PPN leads. So there's a lot of championing of health psychology going on, and we really appreciate that from everybody on the call and from the PPNs. It's been great, actually. The PPNs are a real driving force behind kind of promoting what we do. And so if you are on the call and you haven't joined the PPN, I would urge you to sign up. It's free. You get access to all brilliant things like this, and invited along to hear more about what we all have in common, but also what our specialisms are and what we could bring, especially at a really important time like this where everything's changing. So thanks very much, everybody who's listened, and thanks, Sharon, for inviting us. I'm going to hand over to Kate to close now, but thanks very much to all our speakers, and you're all brilliant, fantastic.
I don't think I can top that. I think that says it all. I mean, huge thanks again, Sharon. I'm on Sharon's PPN committee for North Eastern Yorkshire as the health psychologist, and it's great to just have representation at that level. Thanks hugely to our case study speakers, to Laurel, to Matt, and to Niall, and to you, Liz, as well. Apologies if I got excited with my clicking and went ahead at times, but I'll get better. Thank you, everyone, and thanks to everyone who attended today. And I guess the recording will be available and the slides via the website.
Absolutely. Our emails are on the bottom there. Don't hesitate to be in touch with either of us about anything. I'm involved in lots of different health psychology stuff nationally. I'm always happy to have messages in my inbox about anything to do with health psychology. So please don't be shy. And yeah, thanks very much, and keep on doing what you're doing in promoting health psychology. We're a great supportive community, and it's fab to see so many of you here today. Thanks very much.
Thank you. That was brilliant. Thanks so much.
Brilliant.
Take care.
Thank you.
Take care. Thanks, everyone.
I'll stop recording. Would the presenters like to stay on?
Yeah, just for a minute, if that's all right. That'd be great. People can. They might have to rush off.
You don't have to rush off.